Hello, good morning, everybody. Thank you for inviting me to give a lecture on adverse drug reactions or the consequences that a common drug use may have on health, especially with a focus on effects on the immunosystem. My name is Julia Stingl. I'm the director of the Institute for Clinical Pharmacology at the Aachen University Hospital in Germany. And I would like to present you some data that we collected about the effect of drug-drug gene interactions on the occurrence of adverse drug effects, and with a special focus how these adverse drug effects could influence the immunosystem. On this slide, what you see is a couple of persons who all share a common feature. And the common feature is they all suffer from adverse drug effects. Actually, these pictures come from a serious game of pharmacology for our medical students, where we ask the students to assess the patient's history and to conclude which of the given drugs may have caused the side effect. So all these persons here present symptoms of side effects caused by common drug therapies. And we performed a study where we observed in emergency hospitals or in patients coming to the emergency visits, and we assessed the causality to drug treatment, trying to estimate the number of emergency visits that is caused by adverse drug effects. And indeed, we came up with a number that is shared by other studies as well in Europe and also in the United States, that about 7%, perhaps 10% of the emergency visits are caused by drug therapy. They are caused by side effects of drugs. And we analyzed the vulnerability of the patients. Who are these patients coming to emergency visits because of side effects of their drug therapy? Well, you see here the age, the median age of the people coming to emergency visits. And as you see, these are mostly elderly people. Both sexes are equally distributed, but we clearly can recognize an important risk factor, apparently, for side effects, and this is older age. The median age was 78 of these patients. So if you work in an emergency visit, in an emergency department, if you meet people at elder age waiting in the waiting room, you can ask them, what drugs have you taken? And the probability or the risk that they are here because of a side effect is quite high. So the vulnerability profiles of patients leading to side effects are probably age, older age, but in older age, you also happen to take more drugs. So because of more diseases, comorbidity, morbidity, and polypharmacy are typical features of the elderly. And also the more and more fragility in causing immobility in these patients lead to vulnerability to side effects. And perhaps also our genes may influence the safety of drug treatments. We will look at that in the study. In the region where I live, where we have done these studies, there's an epidemiological study ongoing called the Rhineland study. And the Rhineland study is done in healthy volunteers in a census-based manner. People are included and they will be followed up for 30 years. And it turned out that in the normal population in Germany, in our region where I live, every third person at the age of 65 or older takes more than 3 drugs, and 4 out of 5 persons at the age higher than 65 take at least 1 drug. So we live in a polymedicated population, especially when we are turning over the age of 60. Elderly people are usually taking not only 1 drug, but are taking many drugs at the same time. And this was also visible in this study of side effects where people come to the emergency visits. They all were polymedicated with a mean of 7 drugs at the same time in the persons. So what were the problems? What were the symptoms of adverse drug reaction leading to hospitalization, to emergency visit? Well, it is depicted here in this table. And if we look at the most frequent reasons, they are conditions, more or less unspecific conditions that lead to symptoms of side effects. For example, dehydration is very common in the elderly people, and it causes all our given drugs to increase in plasma concentrations. So all of the drugs taken at the same time have a higher risk for side effects, and they may present all symptoms of side effects that are caused by these drugs in polytherapy. So dehydration, confusion was the second frequent symptom of the people coming to the emergency visit. Then cardiovascular problems, falls, a typical severe side effect in the elderly, quite often causing hip fractures that are associated with a high risk for death, and all kinds of bleeding complications were in the most frequent symptoms that the patient coming to the emergency visit presented. So what about adverse drug reactions and the immunosystem? Well, perhaps you think, okay, we have some drug allergies, but that's it. But this is not the case. Most common adverse drug reactions have an effect on our immunosystem, because the immunosystem is our body's defense system, and it may be modulated by multiple pathways of drugs and by many drugs affecting normal health status. But let me be a little bit more specific. For example, we have a lot of drugs that are somehow immunosuppressive. All the corticosteroids given at multiple indications, very frequently taken by patients presenting with adverse drug reactions. And also immunosuppressants, of course, they have heavy effects on our immunosystem. We know that drugs affecting the microbiome are also affecting the immunoresponse of our body. And for example, we know that cancer treatment with PD-L1 inhibitors targeting our immunosystem is heavily modulated by antibiotic drug treatments, for example, that kill the gut microbiota. So changes in the microbiome of our gastrointestinal tract will have severe effects on the immunoresponse to diseases and will affect the efficacy of immunotherapeutic agents as given in cancer treatment. Or let me give some more examples. Several drugs and many drug classes have an effect on our bone marrow, on blood production, and they may cause agranulocytosis, a famous side effect caused by, for example, antipsychotic drugs, or metamizole, an analgesic drug that is frequently taken over longer time for pain, for all kinds of chronic pain treatment. And it also has the risk of agranulocytosis, causing a severe effect on our immune system with the consequence of severe infections like pneumonia, for example. In general, bone marrow suppression is caused by all kinds of anti-cancer drugs, chemotherapeutic drugs, and we know that these are heavy effects on the immune systems, and the patients have to be protected from normal life because they will get infections and have no immunodefense. We also know that drugs are acting on the inflammatory systemic status in a patient, and we learn more and more what inflammation is causing in our bodies. And most recently, we also got interesting findings on drugs that interact with viral infections and also with the inflammatory status, making people vulnerable to certain infections, for example, the COVID-19 infection. And it was shown that antidepressants, which are drugs acting both on sphingomyelinase activity, that is causing an antiviral effect, but also on anti-inflammatory activity. So they influence the vulnerability towards certain viral infections, and hereby COVID-19 has been shown that people taking antidepressant drugs are somehow protected from the infections with COVID-19, and also the severity of the infections was lower than in people not treated with antidepressants. So we have plenty of ways and pathways how drugs and drug therapy affects our immune system and causes side effects that are deeply affecting immunoreactions of our body. And so it becomes clear that patient vulnerability and polypharmacy also has an effect on adverse drug reactions on the immune system. So what are the most prominent risk factors for adverse effects on the immune system or others? We learned that old age, and this is data from this study looking at patients hospitalized in the emergency departments, they were old, and there were differences in adverse drug effects between the older people and the very old people, the old and the younger old people. For example, bleeding complications were much more frequent in the very old people than in the younger people. And so the severity and also the symptoms of side effects are different in these age groups, causing different vulnerability to side effects. Polypharmacy is causing side effects because we have all kinds of drug interactions that may lead to increases in drug concentration, in drug exposure, which then causes a couple of side effects that are all dose related or exposure related. And in addition to polypharmacy, we also face the genetic profile of the patients. And very often this also interacts with the drug interactions, because if a pharmacogenetic variant affects a certain metabolic pathway, this metabolic pathway may be further affected by polypharmacy. So if you have, for example, a prescription pattern of several drugs that are metabolized via the same pathway, and the patient is also carrier of a pharmacogenetic variant, increasing or decreasing the activity of this metabolic pathway, then polypharmacy together with pharmacogenetics may be fatal or really causing severe side effects. And this is what is usually understood in the assessment of drug-drug gene interactions, how our genetics together with polypharmacy may react to a certain vulnerability phenotype in the patient. We analyzed in the cohort of emergency visits patients. We analyzed the genetic profile in about 1/3 of the cohort, in about 700 people. We got the pharmacogenetic profile, and in the total cohort, we had all the drugs that were taken and the symptoms of side effects. And for example, for the anticoagulants, for clopidogrel, we found out that in the side effects where clopidogrel was suspected to be causative, the risk alleles, the pharmacogenotypes predicting higher risks for clopidogrel side effects were overrepresented. That's what you see here in the orange group, where clopidogrel was suspected to be causative for bleeding complications. The risk genotypes, which are here from the left to the right, with a decrease in risks, the risk phenotypes were more pronounced than in the bleeding complications where clopidogrel was not suspected. And similar risk profiles we could also detect for fenprocomon, another anticoagulant drug similar to warfarin. Here also the low risk genotypes were associated or were less associated with bleeding complications where fenprocomon was suspected, compared to the high risk profiles that were especially associated for the bleeding complications where fenprocomon was suspected. So there seems to be an additive effect of pharmacogenetics in addition to interactions. We also studied the cumulative effect of drug interactions in the case of polytherapy, where we're really taking many drugs at the same time. And here you see the analysis of side effects affecting the brain, like dizziness, syncope, and headache. And we studied whether the number of substrates of a drug metabolizing enzyme, SYP2D6 in that case, if the number of substrates in the medication correlates with the side effect, in the way or the thinking that multiple substrates of a single enzyme may cause a decrease in metabolism, leading to higher concentrations of all the other substrates. And indeed, we found out that for dizziness, this was the case, whereas for the others, we did not see a correlation between the number of substrates. But what you see here, it seems to be an independent factor in addition to old age and also to sex, an own risk by the number caused by the number of substrates of the same metabolic pathway in polypharmacy treated patients. They had 1.6-fold odds ratio compared to people only taking one SYP2D6 substrate. So this may be a hint that the number of substrates also influence the metabolic pathways, and this is an example for drug-drug interaction causing side effects, causing adverse drug effects. The burden of polytherapy is not only in emergency visits. We have here at the University Hospital in Aachen, we have a outpatient clinic for geriatric patients. These patients are even older. In mean, they are older than 80 years old, and they are all taking a lot of drugs at the same time. We have in mean in our patients 16 drugs per patient. And the maximum was actually 35 drugs in one patient every day, 35 drugs. So you don't need to eat much then. And what we found out is that our patients share very similar profiles of drug groups, making it a slightly more, little bit easier to study drug interactions, because they are all treated for the same or for very similar indication. You see here that most of the patients get antithrombotics. They all get painkillers, different substances. They all get a stomach protection proton pump inhibitors. They all take cardiovascular medication, diuretics, statins, and they all take, or most of them, many of them take sleeping pills and sedative agents and also antidepressants. Even if we are not aware of a real diagnosis of depression, many elderly people are on antidepressants in their medication plan. And for analysis of drug interactions of such complex polytherapy patterns, it is certainly not possible anymore with normal methods of a regression analysis. It gets difficult, more difficult. And we think that we will need the methods of data science for analysis of these drug-drug interactions. And one example how this can be done with a graph model was actually published by the Stanford group for assessment of drug interactions, originally for detecting new drug targets and repurposing, but this model or similar models could be developed and used for the assessment of polymedication in real world. So therefore, we are currently developing data analysis pipeline, data science pipeline for our real-world data on drug interactions in patients who are taking really more than 5 drugs and in mean 16 drugs at the same time. So I think here we are, and we need new methods of data science to assess the burden of side effect in real world in our patients today. Yeah, pharmacogenetic analyses have been done, and there are guidelines already around promoting pharmacogenetics in drug therapy. And what can be done is the pharmacogenetic influence can be adjusted in precision dosing. So the individual dose may depend on the individual metabolic clearance, and we can transform differences in oral in clearance of the certain drugs into dose adjustments. And this has been done. For example, here I show you the enzyme CYP2D6 and the substrates, antidepressants, antipsychotic drugs are substrates. And what you see in the columns here is the amount of theoretical dose adjustments to obtain the same plasma concentration in all patients with different genotypes. So PM are the poor metabolizer genotypes and are the ultra rapid metabolizer genotypes. And we can adjust for the differences in clearance caused by the pharmacogenetic polymorphism by adjusting the dosages. But what we cannot yet do is to calculate the individual dose adjustments based not only on pharmacogenetics, but based on the individual polytherapy score, the number of substrates plus the pharmacogenetic genotype. So this is something we should develop for the future, how to calculate dose adjustments in order to optimize safety in every patient. Yeah, and with this, I would like to summarize my lecture. I think I could explain to you that adverse drug effects are very often affecting our immunosystem. So immune-related adverse drug reactions are common, and they are related to drug exposure. There may also be allergic reactions, but most commonly they are related to drug exposure. So with precision dosing, we could also avoid immune-related adverse drug reactions in real world. And for future prediction and better estimation of vulnerability profiles, we certainly will need bioinformatic expertise and the new methods of data science, because we have really a lot of combinations in these situations of polypharmacy with more than 10 drugs taking by the same patients at the same time and interacting not only with each other, but also interacting with the pharmacogenetic profile of the patient. And with this, I wish you a good discussion and conference. And I would be happy to answer questions. You can email it to me or to come somehow into contact what will be discussed in your symposium. And I'm happy to to have been invited to give this lecture. Thank you very much.